and separation anxiety, starting first with social anxiety. And anxiety in general is the third most common mental health disorder. There was a recent meta-analysis that just came out, and I'll share the link with Nicole, and she can send it out, that looks at anxiety in children and the rates that seem to be climbing, and try to come up with some reasons or solutions as to why that's happening, and then interventions. But social anxiety in particular is becoming increasingly common. This is characterized by this intense fear of being humiliated or suffering some sort of embarrassment in social or performance situations. And so they will complain of feeling their heart race or sweating or signs like that. And while it generally occurs a little bit later in childhood, there is some thought that younger children, toddlers, preschoolers, who are excessively shy or socially inhibited may go on to develop this as well. In terms of pathology, how is this happening? We know that it involves the amygdala, and we believe that there's serotonergic and adrenergic functioning, which is why the SSRIs are seemingly helpful in this group. About roughly 10% of U.S. youth at some point in their lifetime experience social anxiety. About 5% of teens, where it seems to be most common, report 7 or more of the 12 types, and I'm going to talk about those 12 types in the next slide. About 3% of teens report fewer than these 7 types. And while we hear a lot about performance anxiety, it's very few who experience that only. Although that's something you'll hear, stage fright or getting up to give a speech or something. There's usually more to it if someone's reporting that. So some typical fears related to social anxiety, which maybe if you're not familiar with this, it seems some counterintuitive. But they have very difficult times meeting new people, particularly their own age. So making friends, being in a room with people their own age, of course, talking to authority figures or any person that they see as an authority figure, going into a room that already has people in it. So if they have to join a party or a class and there's already people in it, it becomes very difficult for them. Talking with people they don't know well, and then, of course, dating or approaching people to date. And then it sort of encompasses any situation where they could be the center of attention or where something embarrassing might happen. And for kids, the thought that something embarrassing might happen could be anything. So it could be as much as, being embarrassed while they're doing homework with someone watching, eating or drinking in public, the typical speaking, acting, or performing in a group, and then test taking. So when we talk about social anxiety, it could incorporate any of these situations. Risk factors, we tend to see this a little more in females than males, although that gap is lessening with more current research. Generally seen in kids greater than 10 years old, and this is when it really starts to impair their functioning, particularly because this is the time when they're more concerned about developing peer relationships and moving away from the family structure. And then this proves difficult because it causes anxiety to participate with others in these ways. Kids who have a history of peer victimization or emotional maltreatment at home. And an interesting finding is that if the child has a father who's experienced social anxiety, they're at more risk to develop this as well. And the thought behind this is that when they see fathers with social anxiety, kids interpret this as a much greater threat than if their mom is anxious. Another finding they're correlating with social anxiety is very low birth weight preemies or infants. Due to the way the structures in the brain are developing, they seem to be at greater risk for this anxiety. Comorbidities that we see along with this, agoraphobia, or not wanting to leave their safe space or their home. Other anxieties are comorbid, so generally if they have generalized anxiety, you want to assess whether or not social anxiety or separation anxiety is present, because that is common as well. PTSD, substance abuse. And the substance use tends to happen as a way to medicate for their symptoms and ADHD. The primary symptom is that there's this avoidance or withdrawal behavior related to any sort of social situation. For younger kids, you'll see crying and temper tantrums or fidgeting and somatic complaints. For older children, we'll also see school refusal, which can become a problem, especially as they need to be in school. And as they're older, it's harder to get them there if they're choosing that that's something they don't want to do. Mild impairment prognosis generally works its way through, and they are able to work through it. If someone's noticing severe avoidance or they're using substances, interventions are required, and it's very suggestive that this will continue into adulthood and interfere with normal development if it's left untreated. So it is something when noticed in children to be addressed, identified, and treated. Okay. Research is suggesting that the combination of psychotherapy and pharmacotherapy offers the best outcomes. At this point, the SSRIs are the first line and the only FDA-approved treatment, although if you use other medications, just the clonidine or things like that, they're non-FDA approved, but they are also found to be effective. The most effective forms of psychotherapy have to do with changing the thoughts associated with their perception and their appraisals of being out in public. And so cognitive restructuring or cognitive behavioral therapies have been especially useful, particularly for kids who are, or teens who are refusing to go to school. Primary prevention is helpful if you notice toddlers or young children with parents who are reporting that they are excessively shy. While some shyness could be traits or something that is normal, excessive shyness or refusing to leave the primary attachment figure is something to be considered. Two psychotherapies that are evidence-based and have shown good improvement in this population are the FRIENDS program and the Coping Cat program. Teens especially have been reporting that they like the Coping Cat since it's computer and they can sort of do it at their own pace. Okay, so now I'm going to move into separation anxiety, and this differs from social anxiety in that there is a very persistent and beyond typical excessive anxiety than we would expect when there's a separation from the attachment figure. Could be separation or impending separation. So if the child knows that the parent or attachment figure is leaving, they'll start the symptoms will start prior to their actual leaving. Separation anxiety is highly correlated with school refusal. About 75% of children who have separation anxiety then also refuse school. And something to consider is to screen for selective mutism, because some kids who have school refusal also have the problem of selective mutism. So it's just something to keep in the back of your mind if you have a kid presenting with this. So it's important for separation anxiety to be distinguished from typical normal separation anxiety that occurs naturally in kids up to 3 to 4 years old, and separation anxiety that's causing impairment. Most of the time, separation anxiety that's causing impairment is for children greater than 3 to 4 years. Normal, typical development, we will see periods of separation anxiety prior to age 4, so that's something to keep in mind and consider. But some of the things that you'll see, kids who are unable to sleep if they're not near the attachment figure, so parents will report that the kid will not sleep alone in their room, they always want to sleep in bed with the parents or whatever. And then tantrums or excessive distress when there's planned separations. Homesickness, these are for kids who maybe have to leave for school or go to a school trip, and they have problems with that. And then these frequent somatic complaints, stomach pain, heart racing, sweating, those kinds of things. And then reports about nightmares about being separated or taken from the primary attachment figure. So these are, symptoms that are distressing. It's distressing to the child, it's distressing to the family. Parents will talk about, I can't leave home, I can't do this without, I can't, go away for the weekend or things like that. Okay. Again, for pathophysiology and risk factors, this is, again, problems with the amygdala and dysregulation, fear and stress response. Again, the very low birth weight infants seem to be at higher risk. If there is a history of an earlier traumatic separation, could be maybe the parent is hospitalized, or there's a divorce that separates for long term, things like that. There is some evidence that some children sort of have a temperament that puts them at higher risk for this. And so paying attention to those types of things among parents. And then female, again, seem to be affected by this more often than males, although current research is saying that that gap is also lessening more currently. Prevalence range, about 1.5% for adolescents, 4 to 5% in the younger school-age children, and a prevalence rate of that should be 2.4%, not 24%. A third of the children who have this also have a comorbid depressive disorder, and then about a quarter of them have ADHD, ODD, or conduct disorder with it. And the question about the ODD and the conduct disorder is kind of that what came first, the chicken or the egg? And the thought is that this untreated separation anxiety leads to these oppositional behaviors. So it's important to treat that as symptoms are shown to help stop the progression to these disruptive disorders. This is a disorder where we see different symptom manifestations based on age. So most commonly, kids less than 8 report fears about losing or fearing harm to their parents or attachment figures and school refusal. 9 to 12, you'll see more excessive distress at time of separation, whether or not it's a weekend or a school trip or things like that. And then we see more of the somatic symptoms and school refusal among the teens and adolescents, or the younger and to older teens. For separation anxiety relaxation techniques have been proven to, or suggested to be successful in helping to deal with anxiety at the time. The cognitive and behavioral therapies help to restructure and reframe the thoughts around what might happen when they're separated from that attachment figure. Family therapy is especially useful in this situation because it tends to create distress and dysfunction among the family, because parents will say, you're old enough to be home alone, what's going on with you? And so then it's more internalized. Is there something wrong with me from the child's perspective? So family therapy is helpful here. The SSRIs are the FDA-approved treatment, but beta blockers and the alpha adrenergic agonists have been effective. They're just not FDA-approved. Some resources that are helpful, the Child Anxiety Network, Boston University-based website, that has lots of information. It has great resources for parents, it has resources for kids, and it has resources for professionals. And then the Anxiety and Depression Association of America, that's a resource for professionals. They have a child and adolescent special interest group that you can join their listserv, and they give you the latest information about anxiety and depression for all ages, but particularly child and adolescents if you're most interested in that. And I think that's it. That's the last slide. Yeah.